Welcome back to The Deep Dive, your shortcut to being well-informed. Today we're diving into the body's hidden conductor, the endocrine system. Think of it as the ultimate orchestra, where tiny chemical messengers, hormones, orchestrate everything from your mood to your metabolism. Our mission in this deep dive is to go beyond the basics, extracting the most important insights so you can truly master this information, understanding the profound disruptions that can occur. Let's really get into what makes this system the body's master conductor and explore its most common and impactful challenges.
It's true, yeah. We're looking at a system where often invisible shifts can trigger enormous systemic impacts. Endocrine diseases generally fall into two broad categories, those tied to too much or too little hormone production, and those involving tumors or mass lesions that may or may not affect hormone levels. To truly grasp these conditions, we need to integrate what the tissues look like, their morphology, with precise measurements of the hormones themselves and their delicate regulators.
That's a great frame for our journey. And to truly understand this intricate network, we're going to start where so many of these signals originate. The body's central command center. Let's talk about the pituitary gland, often called the master gland. It's surprisingly small, about the size of a bean, tucked away safely within a bony cradle at the base of your brain, called the sella turcica. This little gland's function is profoundly controlled by the hypothalamus, a vital part of your brain it's connected to by a delicate stalk. You can almost imagine the pituitary is the central processing unit, right? Taking complex orders from the hypothalamus and then dispatching precise commands to almost every other endocrine gland in your body.
That CPU analogy is spot on, actually, because it's not just one uniform unit. The pituitary actually has two distinct lobes, each with unique origins and functions. The anterior pituitary, making up about 80% of the gland, is essentially a hormone factory. Its specialized cells produce what we call trophic hormones. Think of them as manager hormones that stimulate other distant glands, like your thyroid or adrenal glands, to get to work and produce their own hormones. These include growth hormone, prolactin, ACTH, TSH, and the gonadotropins FSH and LH, which are critical for reproduction. What's really crucial here is that this anterior lobe is under precise control from the hypothalamus, receiving both stimulating and inhibitory signals that travel down a specialized blood vessel network, a portal venous plexus. These signals, in turn, are influenced by specific genetic switches or transcription factors during development. And those genetic markers are actually retained in pituitary tumors, which helps us classify them later on. Now, the posterior pituitary is a completely different story. It's more of a sophisticated storage and release center. This lobe doesn't make its own hormones. Instead, it stores and releases two key peptide hormones, oxytocin and antidiuretic hormone, or ADH, which are actually synthesized way up in the hypothalamus and then transported down nerve axons. Oxytocin is, pretty well known for its role in uterine contractions during labor and milk ejection during lactation. ADH, on the other hand, is your body's critical water conservator. It restricts water loss through the kidneys during dehydration or low blood volume, finely tuned by sensors that detect blood pressure and plasma salt concentration. So unlike the anterior pituitary, which manufactures its own signals, the posterior lobe is a specialized messenger service, dispatching signals from the brain directly into your bloodstream. This is a vital distinction for understanding how problems here can manifest.
Right, that distinction really highlights the pituitary's complex orchestration. So when this central command center runs into trouble, what does it mean for us? It usually boils down to an excess or a deficiency of these powerful hormonal signals, or simply the physical pressure from a growing lesion nearby, causing widespread symptoms throughout the body.
Exactly. And when we talk about hyperpituitarism and excess of pituitary hormones, the most common culprit is an adenoma, a benign tumor arising in the anterior lobe. These adenomas are often classified by the hormones they produce, though some can be plurihormonal, secreting more than one. We distinguish between microadenomas, under a centimeter, and macroadenomas, over a centimeter. Interestingly, adenomas that don't produce hormones or non-functional ones often go unnoticed until they become much larger, presenting later with physical mass effects rather than early hormonal symptoms. It's quite surprising, actually, to learn that autopsy studies show about 14% of people may have these silent pituitary adenomas, most of which are clinically insignificant.
Wow, 14%?
Yeah, it raises an important question, doesn't it? How many of us might be carrying these without ever knowing, and what are the long-term implications of that silent presence?
That's a genuinely surprising fact, and it underscores that it's not just about the hormones. The sheer physical presence and expansion of these tumors, especially given their location next to vital neural structures, can cause serious problems. Any growing pituitary tumor, regardless of whether it's secreting hormones, can exert significant mass effects. We often see radiographic changes in the sella turcica, the bony home of the pituitary. More critically, they can cause visual field abnormalities by compressing the optic nerves or optic chiasm, leading to a classic bitemporal hemianopsia, essentially, a loss of peripheral vision in both eyes. Like any expanding mass in the brain, they can also elevate intracranial pressure, causing headaches, nausea, and vomiting. A severe and acute complication is pituitary apoplexy, an acute hemorrhage into an adenoma. This is a neurosurgical emergency, demanding immediate attention due to rapid swelling, potential cardiovascular collapse, and even sudden death.
And diving into the biology, the development of these adenomas is tied to some fascinating genetic changes. One common mechanism involves activating G protein mutations. Imagine a cell signaling pathway where a G protein is like a switch that turns on hormone production. In about 40% of growth hormone-secreting tumors, a specific mutation in the GNAS gene essentially jams this switch in the on position, leading to uncontrolled cell growth and hormone release. Other mutations, like in the USP8 gene, can protect growth-promoting receptors from degradation, effectively amplifying their signals, especially in ACTH-producing tumors. We also know about genetic predispositions, with about 5% of adenomas linked to inherited syndromes, highlighting how fundamental genetic programming errors can drive these growths. When we look at these adenomas under the microscope, they typically appear soft and well-defined, though they can erode the cella and press on surrounding structures. Up to 30% are considered aggressive, meaning they aren't neatly encapsulated and can infiltrate nearby tissues like the sinuses or even the brain. Histologically, they're characterized by a uniform appearance of cells and a sparse reticulin network, which helps pathologists distinguish them from normal pituitary tissue. Immunohistochemical stains are vital for subtyping, identifying which hormones or genetic markers are expressed. The very name adenoma is even being debated, with some suggesting pituitary neuroendocrine tumor to better reflect their sometimes unpredictable behavior.
That's an interesting debate. Does changing the name really capture the complexity?
Well, that's the question, isn't it? Does it truly capture the complexity, or is it more about managing clinical expectations and patient communication in a clearer way? It's something the field is grappling with.
That's a thought-provoking point about how we name and understand diseases. Now let's look at some specific types of these anterior pituitary adenomas, starting with the most common, lactotroph adenomas, which secrete prolactin. These make up about 30% of hyperfunctioning cases and can vary greatly in size. In women, hyperprolactinemia often causes amenorrhea, galactorrhea, loss of libido, and infertility. It's often diagnosed sooner in women because of the clear disruption to their menstrual cycles. However, in men and older women, the hormonal symptoms can be much more subtle, allowing these tumors to grow into large macroadenomas before they're detected, usually due to mass effects on vision or causing headaches. It's important to remember that elevated prolactin isn't always an adenoma. It can be physiological, from pregnancy or stress, or caused by certain medications or damage to the hypothalamus. Treatment often involves medication that mimics dopamine, which can shrink the tumors, or surgery. The second most common type are somatotroph adenomas, which secrete growth hormone. These are often large at diagnosis because their symptoms develop slowly and insidiously over many years. In children, before their growth plates close, excessive growth hormone leads to gigantism, a dramatic increase in overall body size, often with disproportionately long limbs. In adults, after growth plates have fused, this excess causes acromegaly, leading to a gradual but conspicuous growth in the skin, soft tissues, and bones of the face, hands, and feet, manifesting as a protruding jaw or thickened sausage-like fingers. Beyond these physical changes, patients can also experience diabetes, muscle weakness, hypertension, and even an increased risk of certain cancers. Diagnosis involves looking for elevated growth hormone and IGF-1 levels, and a crucial test is the failure to suppress growth hormone after an oral glucose load. Treatment options include surgery or medications like somatostatin analogs that inhibit growth hormone release. Next, corticotroph adenomas secrete ACTH, which then overstimulates the adrenal glands to produce excess cortisol, leading to Cushing syndrome. These are typically small tumors, often microadenomas. An interesting and aggressive variant is called Crook cell adenoma, identifiable by a ring-like accumulation of cytokeratin. In a dramatic scenario called Nelson syndrome, patients who've had their adrenal glands removed for Cushing syndrome can experience unchecked growth of a corticotroph microadenoma, leading to mass effects and hyperpigmentation because of related hormones. While less common, other pituitary tumors also exist. Gonadotroph adenomas, for example, often produce only small amounts of LH, FSH, and are frequently non-functioning. So they usually present in middle-aged individuals due to neurological symptoms from their size. Thyrotroph adenomas, which produce TSH, are rare causes of hyperthyroidism, Plurihormonal adenomas secrete multiple hormones and are often more aggressive. Null cell adenomas don't produce hormones, presenting solely with mass effects. Finally, pituitary carcinomas are rare, defined by their spread beyond the cella, and are unfortunately highly aggressive. These specific characteristics are crucial as they directly impact diagnosis, prognosis, and the highly tailored treatment strategies for each type of pituitary tumor.
Absolutely. Bringing this all together for hyperpituitarism, the most common cause is an anterior lobe pituitary adenoma. These can be tiny or large, but functional ones announce themselves with distinct endocrine signs, while non-functional ones present silently until mass effects like vision problems appear. Lactotroph adenomas cause high prolactin, leading to issues like amenorrhea and galactorrhea. Somatotroph adenomas cause excess growth hormone, resulting in gigantism in children and acromegaly in adults. And corticotroph adenomas cause excess ACTH, leading to Cushing syndrome. Under the microscope, a key feature distinguishing them is their cellular uniformity and the absence of a reticulin network. It's clear these aren't just random growths, they're precise disruptions of the body's delicate hormonal symphony, each with its own specific set of genetic and morphological characteristics.
Okay, so we've covered the too much side. What about when the signals diminish? Let's explore hypopituitarism. This is defined as a decreased secretion of pituitary hormones, which typically happens when about 75% of the anterior pituitary is lost. And here's where it gets particularly interesting. If problems with the posterior pituitary, specifically diabetes insipidus, also appear, it almost always points to a broader issue originating in the hypothalamus, higher up in the brain.
Exactly. The causes of hypopituitarism are surprisingly diverse, ranging from direct destruction of the gland to issues with its hypothalamic control. Most commonly, it stems from destructive processes within the anterior pituitary itself. Tumors, whether they're non-functioning pituitary adenomas or other benign and malignant masses in the sella, can damage the gland simply through pressure. Traumatic brain injury and subarachnoid hemorrhage are also significant causes, underscoring how vulnerable this tiny area is to head trauma. Even treatments like pituitary surgery or radiation can inadvertently cause damage. We also see dramatic events like pituitary apoplexy, that acute hemorrhage into the pituitary we discussed earlier. This is a neurosurgical emergency that can cause sudden, excruciating headache, vision problems, acute hypopituitarism, and even cardiovascular collapse. Another important cause is Sheehan syndrome or postpartum necrosis, the most common form of ischemic anterior pituitary necrosis. During pregnancy, the anterior pituitary enlarges, but its blood supply doesn't keep pace, making it vulnerable. If a woman experiences severe obstetric hemorrhage or shock, this can lead to infarction and destruction of the pituitary cells. Rath-Cleft cysts, which are developmental remnants, can also expand and compress the gland. And then there's empty sella syndrome, where the pituitary is compressed by cerebrospinal fluid, either due to a congenital defect or after a mass is resolved. Beyond direct pituitary damage, problems in the hypothalamus can also lead to hypopituitarism by disrupting the signals that tell the pituitary to release hormones. Unlike direct pituitary issues, hypothalamic problems can also lead to diabetes insipidus because they impact ADH production. Causes here range from brain tumors to radiation and inflammatory disorders. Rarely, specific genetic defects can cause hypopituitarism from birth. For example, mutations in genes that regulate pituitary development can lead to a deficiency of growth hormone, prolactin, and TSH.
Wow, you can see how incredibly diverse the reasons for diminished hormonal signals can be. And the clinical manifestations are just as varied, acting like pieces of a complex puzzle. For instance, growth hormone deficiency in children leads to pituitary dwarfism, while a lack of gonadotropins causes infertility and decreased libido in adults. Deficiencies in TSH and ACTH will manifest as symptoms of hypothyroidism and hypoadrenalism, which we'll cover later. A lack of prolactin means a mother can't lactate after childbirth. And even a deficiency in melanotropin can cause unusual pallor. Recognizing these specific deficiencies is crucial. Each missing hormonal piece points directly to which pathway has failed, guiding both diagnosis and targeted replacement therapy.
That's right. Which brings us neatly to the posterior pituitary syndromes. These are all about regulating water balance, primarily through ADH. The first is diabetes insipidus, which is caused by a deficiency in ADH. This means your kidneys can't properly reabsorb water, leading to excessive urination or polyuria. The causes are varied, including head trauma, tumors, inflammation of the hypothalamus or pituitary, or surgical complications. Clinically, you excrete large volumes of very dilute urine, leading to increased serum sodium and osmolality, making you incredibly thirsty, a condition called polydipsia. If water intake is restricted, this can lead to life-threatening dehydration. The other extreme is syndrome of inappropriate ADH, or SIADH, caused by excess ADH. This leads to the body over-reabsorbing water, resulting in hyponatremia, low blood sodium. The most common causes are ectopic ADH secretion, often from certain lung cancers, some drugs, or central nervous system disorders. The clinical picture is dominated by hyponatremia, which can cause cerebral edema and neurological dysfunction. While total body water increases, your blood volume stays normal, so you typically don't see peripheral edema. You can see how finely tuned our body's water balance is, and how even subtle changes in ADH can create dramatic and potentially life-threatening fluid and electrolyte imbalances.
That fine-tuning is indeed critical. And to conclude our look at pituitary-adjacent pathology, let's briefly discuss hypothalamic suprasellar tumors. These neoplasms, like gliomas or craniopharyngiomas, can cause either too much or too little pituitary hormone, or even diabetes insipidus. A particularly interesting one is the craniopharyngioma. These slow-growing tumors arise from remnants of a developmental pouch and typically have a bimodal age distribution, affecting both children and older adults. Patients often present with headaches and visual disturbances, and in children, growth retardation due to growth hormone deficiency is a common sign. Craniopharyngiomas are typically cystic or multiloculated and can grow quite large, pressing on the optic chiasm or other brain structures. We recognize two main types: the adamantinomatous craniopharyngioma, more common in children, often with calcifications and cysts filled with a machine oil-like fluid. This type is linked to specific mutations in the CTNMB1 gene. The papillary craniopharyngioma, more common in adults, has a different histological pattern and is often characterized by activating BRAV600E gene mutations. This genetic insight is significant because it opens the door for targeted therapies using BRAF inhibitor drugs. The prognosis is generally excellent, especially for smaller lesions. These tumors highlight the complex interplay between developmental origins, anatomical location, and specific genetic mutations, all of which dictate their clinical presentation and management. Okay, let's transition now to a gland that truly deserves the title metabolic maestro, the thyroid. This butterfly-shaped gland sits at the base of your neck, just below your larynx, and is a critical regulator of your body's energy. It originates from the pharyngeal epithelium during development, which explains why, rarely, you might find thyroid tissue in an unusual spot, like at the base of the tongue. Inside, it's packed with tiny follicles, each lined by cells that produce and store key hormones. If the pituitary is the central command, then the thyroid is undoubtedly the body's metabolic maestro, dictating energy levels, growth, and development with precision.
It's an incredibly precise system indeed. The thyroid hormone story begins with the hypothalamus and pituitary, which sends signals to the thyroid via TSH, or thyroid-stimulating hormone. TSH binds to receptors on the thyroid cells, prompting them to synthesize and release two key hormones, thyroxine, T4, and triiodothyronine, T3. T3 is about 10 times more potent than T4. Once in the bloodstream, these hormones mostly bind to plasma proteins, forming a vital buffer to ensure a steady supply. In your body's peripheral tissues, T4 is often converted to the more active T3, which then binds to receptors in your cells, stimulating genes that control metabolism. The effects of thyroid hormone are widespread. It boosts carbohydrate and lipid metabolism, increases protein synthesis, and generally elevates your basal metabolic rate, effectively turning up your body's energy production. It's also crucial for brain development in fetuses and newborns. We also encounter goitrogens, which are chemical agents that can inhibit thyroid function. By suppressing T3-T4 synthesis, these can cause TSH levels to rise, leading to an enlarged thyroid or a goiter. Examples include certain medications and even some foods if consumed in very high amounts. Inside the thyroid, there are also special C cells that produce calcitonin, a hormone involved in calcium regulation, helping to deposit calcium in bones. What's truly elegant here is this multi-layered feedback loop, ensuring tight control over a hormone that impacts virtually every cell in your body, from your brain to your metabolism.
That elegance is profound. And when this maestro plays out of tune, we face a spectrum of conditions. Excessive thyroid hormone, known as hyperthyroidism, deficient thyroid hormone, hypothyroidism, or various mass lesions. Let's first explore what happens when the thyroid goes into overdrive.
Okay, let's clarify our terms first. Thyrotoxicosis describes a hypermetabolic state caused by elevated levels of free T3 and T4. Hyperthyroidism is the most common cause of thyrotoxicosis, resulting from the thyroid gland itself overproducing hormones. However, not all thyrotoxicosis is hyperthyroidism. Sometimes performed hormones are released without the gland actually working overtime, as in some inflammatory conditions. The vast majority of hyperthyroidism cases, about 85%, are due to an autoimmune condition called Graves' disease. But it can also be caused by hyperfunctional nodules or adenomas.
And the clinical features of hyperthyroidism are incredibly varied, aren't they? Affecting almost every system in your body. Patients often experience skin that's soft, warm, and flushed, and a constant feeling of heat intolerance and increased sweating, reflecting a higher metabolic rate. Despite an increased appetite, they often lose weight because their body is burning through calories so rapidly. The heart is one of the first organs to show symptoms. Patients commonly experience a racing heart, tachycardia, palpitations, and sometimes an enlarged heart. Arrhythmias like atrial fibrillation are frequent, particularly in older patients. In severe cases, this sustained stress on the heart can even lead to congestive heart failure. Beyond the heart, the nervous system is often overstimulated, leading to tremors, hyperactivity, emotional lability, anxiety, and insomnia. Muscle weakness is also common. Even the eyes can show symptoms, with a wide, staring gaze and lid lag due to sympathetic overstimulation. However, the prominent bulging eyes, known as exophthalmos, is a unique feature of Graves' disease. In severe acute cases, patients can experience thyroid storm, an abrupt and life-threatening surge of hyperthyroidism, often triggered by stress, leading to fever and dangerously rapid heart rates. This sheer variety of symptoms, affecting nearly every organ system, makes hyperthyroidism a master of disguise, often mimicking other conditions, underscoring why a broad diagnostic approach is critical.
Absolutely. Diagnosing hyperthyroidism relies heavily on laboratory tests. A low TSH level coupled with increased free T4 is the most useful screening test. TSH levels will decrease even in very early stages as the body tries to shut down the overactive thyroid. Once confirmed, a radioactive iodine uptake scan helps pinpoint the cause. Diffusely increased uptake suggests Graves' disease, while increased uptake in a single spot indicates a toxic nodule, and decreased uptake points to an inflammatory process like thyroiditis. Treatment options are diverse. Beta blockers can manage the adrenergic symptoms like a racing heart, while thionomides block new hormone synthesis. Radioactive iodine can gradually ablate the thyroid, and sometimes surgery is required for large goiters. The broad range of treatments reflects the different points of intervention in the complex thyroid hormone pathway, each tailored to the specific cause and presentation.
Okay, so now let's explore hypothyroidism when the metabolic pace slows down. This is a common and often insidious condition, defined as any problem that interferes with the thyroid's ability to produce hormones. It's quite prevalent, especially as we age, and is much more common in women. Hypothyroidism can be primary, meaning the problem is with the thyroid gland itself, or secondary, meaning it stems from an issue in the hypothalamus or pituitary. This condition is far more common than many realize, and its subtle, slow onset can make it a real diagnostic challenge, often mimicking other common complaints.
Definitely. The causes of primary hypothyroidism are varied. Globally, congenital hypothyroidism is most often due to endemic iodine deficiency in the diet. Rarer forms involve inherited defects in how the thyroid makes hormones. For adults, the most common cause in iodine-sufficient regions is autoimmune hyperthyroidism, primarily Hashimoto thyroiditis. Here, the body's immune system mistakenly attacks its own thyroid cells, leading to gradual destruction. Patients typically have circulating autoantibodies against thyroid components. Hypothyroidism can also be iatrogenic, meaning caused by medical intervention, such as surgical removal of the thyroid, radiation therapy, or certain medications like lithium.
And secondary or central hypothyroidism.
That's less common, stemming from deficiencies of TSH from the pituitary or TRH from the hypothalamus. This can result from any of the hypopituitarism causes we discussed earlier, such as pituitary tumors, trauma, or radiation damage. The clinical syndromes associated with hypothyroidism depend heavily on when the deficiency occurs. Cretinism refers to severe hypothyroidism developing in infancy or early childhood. Historically linked to iodine deficiency in certain regions, it leads to severe intellectual disability, short stature, coarse facial features, and a protruding tongue. The timing of thyroid deficiency during development is crucial, as maternal thyroid hormones are essential for fetal brain development. Myxedema, on the other hand, describes hypothyroidism in older children or adults. Its onset is insidious, often taking years to be noticed. Myxedema is characterized by a profound slowing of physical and mental activity. Patients experience generalized fatigue, apathy, mental sluggishness that can mimic depression and slowed speech. They often feel cold, are frequently overweight, and experience constipation. The skin becomes cool and pale, and cardiac output is reduced, contributing to shortness of breath. There's also an accumulation of matrix substances in the skin and other tissues, leading to non-pitting edema, a broadening of facial features, an enlarged tongue, and a deepened voice. Myxedema isn't just about feeling tired, it's a profound systemic slowdown that affects nearly every aspect of physical and mental function, from your heart rate to the texture of your skin.
Given how easily the subtle signs of hypothyroidism can be missed or mistaken for other conditions, accurate and timely laboratory testing is your ultimate guide to proper diagnosis and treatment. Lab evaluation is vital because the symptoms are so nonspecific. We often recommend assessing for hypothyroidism in patients with unexplained weight gain or high cholesterol. The most sensitive screening test is a TSH level, which will be increased in primary hypothyroidism as the pituitary tries harder to stimulate the feeling thyroid. However, in secondary hypothyroidism from pituitary or hypothalamic issues, TSH levels may not be elevated. T4 levels, however, will be decreased regardless of the cause.
Right, which leads us to an inflammation of the thyroid itself, thyroiditis. This is a diverse group of inflammatory conditions. We'll look at 3 common and clinically significant types, each illustrating different inflammatory mechanisms.
Okay, first we have Hashimoto thyroiditis, the autoimmune attacker. This is an autoimmune disease where the body's immune system mistakenly attacks and gradually destroys the thyroid gland, leading to progressive thyroid failure and becoming the most common cause of hypothyroidism in iodine-sufficient regions. It predominantly affects middle-aged women. The core problem is a breakdown in the body's self-tolerance, leading to the production of autoantibodies against thyroid components. This condition has a strong genetic component, sharing some genetic predispositions with other autoimmune diseases. Immune cells, particularly cytotoxic T cells, directly destroy follicular cells. Hashimoto thyroiditis is a classic example of the body's own defense system mistakenly turning on itself, leading to chronic destruction and widespread health implications that extend beyond just the thyroid. Morphologically, the thyroid gland in Hashimoto thyroiditis is typically diffusely enlarged and firm. Under the microscope, you see extensive infiltration by immune cells, lymphocytes, and plasma cells, often forming germinal centers, almost like mini lymph nodes within the thyroid. The thyroid follicles themselves become atrophic, and their lining cells transform into characteristic Hursley cells, which have abundant eosinophilic cytoplasm. Clinically, it often presents as a painless thyroid enlargement, usually with some degree of hypothyroidism. Occasionally, there's a brief phase of hyperthyroidism called hashitoxicosis, where damaged follicles release stored hormones. Patients with Hashimoto's are also at increased risk for other autoimmune diseases and even for certain types of thyroid lymphoma.
Next, subacute lymphocytic or painless thyroiditis is a presumed autoimmune condition, often occurring after pregnancy, where it's called postpartum thyroiditis. Morphologically, it shows lymphocytic infiltration and disruption of thyroid follicles. But crucially, it lacks the prominent fibrosis and Hursley cells of Hashimoto thyroiditis. Clinically, it typically presents with mild, transient hyperthyroidism, a painless goiter, or both. Many patients recover, but some may progress to overt hypothyroidism.
And finally, granulomatous or decurvain thyroiditis.
All right, this is a painful, self-limited form, much less common than Hashimoto's. It's strongly suspected to be triggered by a viral infection, as most patients report a recent upper respiratory illness. This means the immune response is virus-initiated and not self-perpetuating, allowing the process to resolve on its own. Morphologically, the thyroid can be unilaterally or bilaterally enlarged and firm. Under the microscope, you'd see characteristic granulomatous inflammation with multinucleate giant cells engulfing colloid. Clinically, it's the most common cause of thyroid pain. The inflammation and hyperthyroidism are transient, usually resolving in a few weeks, even without specific treatment. A key diagnostic differentiator is that radioactive iodine uptake is diminished, unlike in Graves' disease. Other rare forms exist, like Riedel thyroiditis, which causes extensive fibrosis, mimicking thyroid carcinoma. Understanding the nuances between these various inflammatory conditions is crucial for guiding treatment and prognosis, especially when differentiating them from more serious conditions like thyroid cancer. Thyroid inflammation isn't a single entity. It's a spectrum of diseases, each with unique triggers, immune responses, and clinical courses. So, to consolidate, Hashimoto thyroiditis is autoimmune and causes progressive destruction. Subacute lymphocytic thyroiditis is often postpartum and painless. And granulomatous thyroiditis is painful, self-limited, and likely viral.
Got it. Okay, let's turn our attention to Graves' disease, the most common cause of endogenous hyperthyroidism. Named after Robert Graves' observations in the 1800s, it's famous for its classic triad: hyperthyroidism with a diffusely enlarged thyroid. infiltrative ophthalmopathy causing bulging eyes, exophthalmos, and in a minority, localized infiltrative dermopathy, often called precubital myxedema. It typically affects women much more frequently than men, peaking between 20 and 40 years of age. Graves' disease is a traumatic and often visually striking example of autoimmunity gone awry, affecting not just the thyroid, but the eyes and skin too.
Absolutely. The pathogenesis of Graves' disease is a compelling story of autoimmunity. It's characterized by the production of autoantibodies, most importantly against the TSH receptor. The key antibody, thyroid-stimulating immunoglobulin, TSI, acts like a mimic. It binds to the TSH receptor and stimulates the thyroid gland, constantly signaling it to produce more hormones, just as TSH would. This is why the thyroid goes into overdrive. The genetic susceptibility for Graves' disease actually overlaps with that of Hashimoto thyroiditis, suggesting a shared autoimmune basis. The distinct infiltrative ophthalmopathy, or Graves' orbitopathy, is also autoimmune. Activated immune cells secrete cytokines that stimulate cells in the retroorbital space to proliferate and produce excess extracellular matrix proteins. This leads to marked infiltration of connective tissue, inflammation, edema, and swelling of the eye muscles, along with an accumulation of hydrophilic substances and increased fat cells. These changes physically push the eyeballs forward, causing exophthalmos, and can interfere with muscle function.
So it's the same autoimmune attack, but manifesting differently in the eyes.
Essentially, yes, it raises an important question. What's truly fascinating here is how a single autoimmune attack on the TSH receptor can lead to such a cascade of diverse effects, manifesting as both systemic hormonal overdrive and localized, visible changes in the eyes and skin.
That cascade of effects is truly remarkable. Morphologically, in Graves' disease, the thyroid gland is usually symmetrically enlarged due to diffuse overgrowths of its follicular cells. Under the microscope, these cells are tall and crowded, often forming small, finger-like projections into the follicle lumen. Though crucially, these projections lack the fibrovascular core seen in papillary carcinoma. The colloid, the stored hormone, appears pale and resorbed. You'll also see immune cell infiltrates throughout the gland. Clinically, beyond the general symptoms of hyperthyroidism, the diffuse thyroid enlargement can often produce an audible bruit from increased blood flow. The ophthalmopathy can persist or even worsen after successful treatment of the hyperthyroidism, potentially leading to corneal injury or extraocular muscle weakness. Lab findings show elevated free T4 and T3 levels and a very low TSH. Radioiodine scans show diffusely increased uptake. Treatment options include beta blockers for symptoms, thioamides to reduce hormone synthesis, radioactive iodine ablation, or surgical removal. Graves' disease is a prime example of why a holistic diagnostic approach, considering both systemic hormonal effects and localized autoimmune manifestations, is absolutely critical for effective long-term management. Okay, let's now talk about goiter, simply defined as an enlargement of the thyroid gland. This condition most often arises from impaired thyroid hormone synthesis, frequently due to dietary iodine deficiency. When hormone production is low, the pituitary responds by releasing more TSH, which acts as a growth signal, causing the thyroid's follicular cells to hypertrophy and hyperplasia. This compensatory growth leads to an enlarged gland. Usually this increased functional mass is enough to maintain a normal euthyroid state, but severe deficiency can lead to hypothyroidism and goiter. The degree of enlargement depends on how long and how severely the hormone deficiency persists. We primarily categorize goiters into two types: diffuse non-toxic, or simple, and multinodular. Imagine your thyroid working overtime, desperately trying to keep up with demand, and in doing so, it simply gets bigger and bigger, sometimes dramatically so.
That's a perfect visual. Let's start with diffuse non-toxic or simple goiter. This involves the uniform enlargement of the entire gland without nodularity, often called colloid goiter because the follicles swell with stored colloid. It occurs both endemically in iodine-poor regions and sporadically. Endemic goiter was historically prevalent in mountainous areas, but widespread iodine supplementation has significantly reduced its incidence, though millions globally remain at risk. Beyond iodine deficiency, certain dietary substances, called goitrogens, can interfere with hormone synthesis and contribute to goiter. Sporadic goiter is less common, more often affecting women, and its cause isn't always clear. Simple goiter evolves through two phases: a hyperplastic phase, where the gland is modestly and symmetrically enlarged with crowded follicular cells, and a colloid involution phase, where if iodine supply improves, the stimulated epithelium involutes, and the follicles become distended with colloid. Clinically, most individuals with simple goiters are euthyroid, and symptoms are mainly related to the physical mass of the enlarged gland, which can cause pressure. The simple goiter is a remarkable adaptive mechanism, but it highlights the critical role of dietary factors like iodine in maintaining thyroid health.
That's a fascinating example of the body's adaptation. But with time, repeated cycles of hyperplasia and involution often lead to a more irregular enlargement known as multinodular goiter. Virtually all long-standing Sibyl goiters eventually progress to this more complex form. These can produce extreme thyroid enlargements, sometimes weighing several pounds, and are frequently mistaken for neoplasms. They also occur in both sporadic and endemic forms, typically affecting older individuals. The progression to multinodular goiter is thought to involve variations in how individual follicular cells respond to growth stimuli. Some cells might develop a growth advantage, perhaps due to acquired genetic changes, allowing them to proliferate autonomously and form nodules. The physical stress from growth and colloid accumulation can also lead to rupture of follicles and blood vessels, resulting in hemorrhage, scarring, and calcifications, all of which further contribute to the irregular nodular appearance. Morphologically, multinodular goiters are multi-lobed, asymmetrically enlarged glands. Their unpredictable growth can cause pressure on vital structures like the trachea and esophagus, leading to breathing or swallowing difficulties. It can even grow downwards into the chest, forming a plunging goiter. On cut section, you see irregular nodules filled with varying amounts of colloid, often with evidence of old hemorrhage, fibrosis, and calcification. Microscopically, you'll find a mix of colloid-rich follicles and areas of active hyperplasia. A key point for pathologists is the absence of a prominent capsule between these hyperplastic nodules and the surrounding thyroid tissue, which helps distinguish them from true follicular neoplasms. Clinically, the dominant features are mass effects, from cosmetic concerns to airway obstruction or difficulty swallowing. Most patients are euthyroid or has subclinical hyperthyroidism. However, in about 10% of patients, an autonomous nodule within a long-standing goiter can begin to produce excessive thyroid hormone, leading to hyperthyroidism, a condition called toxic multinodular goiter or plumber syndrome. While the risk of malignancy is low, sudden changes in size or new symptoms like hoarseness should raise concern. Diagnosis often involves a radioiodine scan, which shows uneven uptake, and fine needle aspiration biopsy to distinguish hyperplasia from a true neoplasm. Multinodular goiter illustrates the progression from simple adaptation to a complex, structurally altered gland, where clinicians must constantly weigh the risk of mass effects and the potential, albeit low, for malignancy. Okay, let's now explore the spectrum of thyroid neoplasms, where a solitary thyroid nodule is a very common clinical presentation. This is a palpably discrete swelling in an otherwise normal thyroid with an estimated incidence of 1–10% in adults. The primary concern, of course, is the possibility of malignancy. Fortunately, the vast majority are benign, such as cysts or follicular adenomas. However, even if only about 1% of solitary nodules are malignant, that still translates to thousands of new cases of thyroid carcinoma each year. It's a bit of a paradox. Despite a rising incidence globally, especially of small papillary cancers, mortality from thyroid cancer remains remarkably low, over 98% 5-year survival, largely due to early detection. This has even led to recent changes in nomenclature to prevent overdiagnosis and overtreatment of very low-risk lesions. Certain clinical clues can raise suspicion for malignancy. Solitary nodules, those in younger patients or in males, are more concerning. A history of radiation to the head or neck significantly increases risk. Conversely, hot nodules, those that actively take up radioactive iodine on imaging, are much more likely to be benign. Ultimately, definitive diagnosis relies on fine needle aspiration, or FNA, or surgical biopsy. This seemingly innocent lump in the neck can be a complex diagnostic puzzle, where every piece of information, from patient history to imaging, helps us solve the mystery and guide potentially life-saving decisions.
That's a critical point, and it emphasizes the multidisciplinary approach needed. Thyroid carcinomas are broadly categorized into papillary, the most common, 85%, follicular, 10–15%, poorly differentiated and anaplastic, less than 5%, and medullary, 5%. Most originate from the follicular epithelium, with medullary carcinoma being the exception, arising from C cells. We're increasingly thinking about these cancers through a multi-step pathogenesis model, where less aggressive precursor lesions can evolve into more aggressive forms through the acquisition of additional mutations. The more aggressive types, like anaplastic and medullary carcinomas, are the main causes of thyroid cancer mortality.
And the molecular understanding of thyroid cancer is truly revolutionizing how we diagnose and treat these diseases, isn't it? We're seeing distinct genetic drivers for different types of thyroid cancer, often involving components of the receptor tyrosine kinase RTK pathway. For example, many conventional papillary thyroid carcinomas are driven by either gene fusions, like in the EE or NTRK genes, or point mutations in the BRAF gene, specifically the BRAF-V600E mutation. This BRAF mutation is associated with more aggressive features and is a virtual hallmark for certain variants. In contrast, follicular neoplasms often show mutations in RAS genes or fusions involving PAX8-PPRG. For most aggressive forms, like poorly differentiated and anaplastic carcinomas, additional mutations in genes like TP53, CTNNB1, and TERT play central roles. Medullary thyroid carcinomas, which originate from C cells, are often linked to activating point mutations in the ET proto-oncogene, both in sporadic and familial cases. Environmental factors also play a role. Exposure to ionizing radiation, especially in childhood, is a major risk factor, leading to a higher frequency of gene fusions. Dietary iodine deficiency is associated with a higher incidence of follicular lesions. This molecular landscape is incredibly detailed, revealing precise genetic changes that drive different subtypes. This understanding is revolutionizing how we diagnose and, increasingly, how we can target these cancers with specific therapies, like BRAF inhibitors.
Absolutely. Let's delve into the most common type, papillary carcinoma, or PTC. This accounts for about 85% of cases, often linked to radiation exposure, and its incidence has risen partly due to better detection of small, low-risk lesions. Grossly, PTCs can be solitary or multifocal, sometimes well-defined, other times infiltrative, often with fibrosis and calcification. Microscopically, the hallmarks are very distinctive, even without the papillary architecture. The nuclei have a characteristic ground glass or orphan Annie eye appearance due to finely dispersed chromatin. You also often see nuclear grooves and pseudo-inclusions, as well as concentrically calcified structures called Samoma bodies. Lymphatic invasion is common, but the prognosis is generally excellent, with a 10-year survival rate over 95%. A significant recent update in nomenclature has reclassified encapsulated follicular variants of papillary thyroid cancer without capsular invasion as non-invasive follicular thyroid neoplasm with papillary-like nuclear features, or NIFTP. This reflects their very low risk of recurrence and metastasis, allowing for less aggressive treatment.
That's a huge development for patients, right? Avoiding overtreatment.
Exactly. This shift is a huge win for patients, showing how cutting-edge pathology directly impacts patient care and quality of life. Moving to follicular carcinoma, which makes up 5–15% of the cases. These are typically single nodules, often difficult to distinguish from benign follicular adenomas by gross appearance alone. Microscopically, they're composed of uniform cells forming small follicles, but crucially, their nuclei lack the features of papillary carcinoma. The definitive diagnosis relies on extensive sampling of the tumor capsule to exclude capsular and/or vascular invasion. This meticulous pathological examination is the gold standard, as cytologic detail isn't enough. Unlike papillary cancers, follicular carcinomas primarily spread via the bloodstream, often metastasizing to bone, lungs, and liver. Prognosis depends heavily on the extent of invasion. The microscopic line between a benign follicular adenoma and a carcinoma is incredibly fine, making meticulous pathological examination of the capsule the gold standard for diagnosis and prognosis. Poorly differentiated and anaplastic undifferentiated carcinomas are the highly aggressive forms, representing less than 5% of thyroid tumors, but with a mortality rate approaching 100% for anaplastic lesions. They typically affect older patients and often arise from pre-existing well-differentiated carcinomas, suggesting a process of de-differentiation. These are the raging fires of thyroid cancer, presenting as rapidly enlarging neck masses, often having already spread beyond the thyroid or to the lungs at diagnosis. Anaplastic carcinomas are among the most aggressive known cancers, with death usually occurring within a year. Immunotherapy is now being explored to improve their dire prognosis. Finally, medullary carcinoma, which originates from the parafollicular C cells. These neuroendocrine tumors, making up about 5% of cases, secrete calcitonin, which is a crucial biomarker for diagnosis and follow-up. About 70% are sporadic, while 30% are familial, occurring in the context of syndromes like MN2. Activating mutations in the RET proto-oncogene are key to their development. Morphologically, a characteristic finding is amyloid deposits within the tumor stroma derived from calcitonin. In familial cases, a precursor lesion called C-cell hyperplasia is often seen. Clinically, they can present as a neck mass or sometimes with paraneoplastic syndromes like diarrhea. Prophylactic thyroidectomy is offered to asymptomatic individuals with known germline RET mutations to prevent inevitable carcinoma. The RET proto-oncogene is a central player, dictating the development and aggressiveness of medullary carcinomas, particularly in the genetically predisposed.
As a final note on thyroid pathology, let's briefly mention congenital anomalies like the thyroglossal duct cyst. This is the most common clinically significant anomaly, a persistent remnant of the thyroid's developmental pathway. These typically appear as spherical masses in the midline of the neck, often becoming evident in adulthood. They can become infected, forming abscesses, and rarely can give rise to cancers. Even small developmental remnants can become clinically significant later in life, reminding us that development is a complex dance with lasting implications.
Exactly. So, to consolidate our understanding of thyroid neoplasms, most present as solitary nodules, but only a small fraction are malignant. Their development is driven by multiple genetic pathways. For instance, papillary carcinomas often involve bare-off mutations or gene fusions, while follicular neoplasms are linked to RAS mutations. The distinction between benign follicular adenomas and carcinomas rests crucially on evidence of capsular or vascular invasion. Papillary carcinomas are diagnosed by distinctive nuclear features even without classic papillary architecture and have an excellent prognosis despite common lymphatic spread. The recent reclassification of NIFTP highlights the importance of distinguishing very low-risk lesions. Poorly differentiated and anaplastic carcinomas are aggressive and often lethal, thought to arise from more differentiated forms. Medullary cancers from C cells are characterized by amyloid deposits and often REAT proto-oncogene mutations. Given this intricate web of genetic drivers and morphological variations, how can we continuously improve early detection and targeted therapies, especially for those highly aggressive forms, to truly minimize patient impact?
That's a critical question. Okay, let's shift our focus now to the parathyroid glands, those vigilant guardians of calcium homeostasis. These four small glands are typically nestled near the thyroid, though they can sometimes be found in ectopic locations like the carotid sheath or thymus. They're primarily composed of chief cells, which secrete parathyroid hormone, or PTH. Imagine your bones as a vast calcium bank, and the parathyroid glands as the vigilant bank managers, constantly adjusting deposits and withdrawals to maintain a precise balance.
That analogy perfectly captures their critical role. The parathyroid gland's main job is to regulate calcium homeostasis, with their activity directly controlled by the levels of free or ionized calcium in your blood. When free calcium levels drop, PTH synthesis and secretion are stimulated. PTH then acts on multiple fronts to raise serum calcium. It tells the kidneys to reabsorb more calcium and excrete more phosphate, and it stimulates the conversion of vitamin D to its active form, which boosts calcium absorption from your gut. Crucially, PTH also enhances osteoclast activity, leading to bone resorption and the release of calcium. The net effect is an elevation of free calcium, which in turn feeds back to inhibit further PTH secretion. Unlike thyroid tumors, parathyroid gland tumors usually come to attention because of excessive PTH secretion rather than from their physical mass. This is how precisely PTH orchestrates calcium levels through these four distinct but interconnected mechanisms, ensuring a vital balance for everything from nerve function to bone integrity.
It's truly an elegant system for maintaining such a critical balance. But when this balance is disrupted, we get hyperparathyroidism, caused by elevated PTH, which is classified into primary, secondary, and tertiary types.
Right. Primary hyperparathyroidism, where PTH is autonomously overproduced, is one of the most common endocrine disorders and a major cause of hypercalcemia. Most cases are now identified incidentally during routine blood tests, with patients often being asymptomatic. It's predominantly a disease of adults, especially women over 50. The most common cause, accounting for 85–95% of cases, is a solitary parathyroid adenoma. Less commonly, it's due to primary hyperplasia, where all four glands are involved, or rarely, parathyroid carcinoma. Genetically, sporadic adenomas often involve inversions in the cyclin D1 gene, leading to overexpression of this cell cycle regulator. Mutations in the MEN1 gene are also seen in a significant portion of sporadic and familial cases. For the rare parathyroid carcinomas, mutations in the CDC73 gene, which encodes parafibromin, are frequently found. Morphologically, parathyroid adenomas are almost always solitary, well-circumscribed, and typically weigh between 0.55 grams. The other parathyroid glands are usually normal or shrunken due to the feedback from the high calcium. Microscopically, adenomas are mostly composed of uniform chief cells, often with a rim of compressed, normal parathyroid tissue. Primary hyperplasia classically involves all four glands, though often asymmetrically, with increased chief cells and inconspicuous fat. Parathyroid carcinomas are rare but can be circumscribed or invasive. Their diagnosis relies on clear evidence of invasion into surrounding tissues or metastasis, as their cellular appearance alone isn't reliable. Prolonged elevated PTH and calcium can lead to changes in other organs. In the skeletal system, you can develop osteoporosis and, in severe cases, osteitis fibrosis cystica, a combination of increased osteoclast activity, fibrosis, and brown tumors, lesions from microfractures and hemorrhage. However, these severe bone changes are now rarely seen due to earlier diagnosis. In the urinary tract, nephrolithiasis or kidney stones occurs in about 20% of patients, and calcium can also deposit in the renal tubules, a condition called nephrocalcinosis. Metastatic calcification can also affect other organs like the stomach, lungs, and heart. Clinically, while many primary hyperparathyroidism cases are now asymptomatic, the classic symptoms are vividly summarized by the mnemonic painful bones, renal stones, abdominal groans, and psychic moans.
Ah, yes, the famous mnemonic.
Exactly. It captures the bone pain, kidney stones, gastrointestinal issues like constipation, and neurological symptoms such as depression or lethargy. It's important to distinguish this from hypercalcemia caused by malignancy, which is the most frequent cause of symptomatic hypercalcemia.
Yep.
In those cases, PTH levels are typically low, whereas in primary hyperparathyroidism, PTH is inappropriately elevated. This is how painful bones, renal stones, abdominal groans, and psychic moans isn't just a catchy mnemonic, it's a dramatic and vivid summary of how unchecked parathyroid activity can echo throughout the entire body.
That mnemonic truly captures the systemic impact. Now let's turn to secondary hyperparathyroidism. This is caused by any condition leading to chronic low calcium, which then triggers compensatory overactivity and hyperplasia of the parathyroid glands. The most common cause is chronic renal failure. Here's why. Failing kidneys struggle to excrete phosphate, leading to high phosphate levels, which in turn depress serum calcium. The kidneys also can't produce enough active vitamin D, further impairing calcium absorption. All these factors stimulate the parathyroids to work harder. Morphologically, all 4 parathyroid glands become hyperplastic. Clinically, the features are dominated by the underlying renal failure, and skeletal changes are usually milder than in primary hyperparathyroidism. In a minority of patients, this prolonged stimulation can cause the parathyroid glands to become autonomously hyperactive even after the original low calcium cause is resolved, for example, after a kidney transplant. This is called tertiary hyperparathyroidism and may require surgery. These distinctions are critical because they dictate vastly different management strategies for hyperparathyroidism, emphasizing the importance of identifying the root cause of the calcium imbalance.
Absolutely. To consolidate our understanding of hyperparathyroidism, primary hyperparathyroidism is the most common cause of asymptomatic hypercalcemia, usually due to a solitary adenoma. Its classic symptoms are painful bones, renal stones, abdominal groans, and psychic moans, reflecting the widespread impact of high calcium. Secondary hyperparathyroidism is most often caused by renal failure, leading to compensatory parathyroid hyperplasia. Malignancies, which often produce PTH-related proteins, are the most common cause of symptomatic hypercalcemia. You can see how finely interwoven calcium regulation is with so many other bodily systems, and how disruptions in the small gland can echo throughout the body with profound consequences.
Indeed, the ripple effects are significant. Now let's consider hypoparathyroidism, which is far less common than its hyper counterpart. This condition involves too little PTH, leading to low blood calcium, and its causes are typically acquired almost always surgical or genetic.
Right. The causes of hypoparathyroidism are important to understand. Surgically induced hypoparathyroidism is the most common, often occurring accidentally during thyroidectomy if the tiny parathyroid glands are inadvertently removed or damaged. Autoimmune hypoparathyroidism, where the body's immune system attacks its own parathyroid glands, can also occur, sometimes as part of a broader autoimmune syndrome. Genetic causes include conditions like autosomal dominant hypoparathyroidism, where mutations in a calcium-sensing receptor gene lead to inappropriate suppression of PTH. Congenital absence of the parathyroid glands can also occur, sometimes associated with other developmental abnormalities. The clinical features of hypoparathyroidism are directly related to the severity of low blood calcium. The hallmark is tetany, characterized by neuromuscular irritability. Symptoms can range from tingling in the extremities and muscle spasms to life-threatening laryngospasm and generalized seizures. Classic physical signs that clinicians look for include Schwastik sign, facial muscle twitching when tapping near the facial nerve, and Trousseau sign, carpal spasms induced by blood pressure cuff. Patients can also experience mental status changes like anxiety, depression, or confusion. Intracranial calcifications, eye problems like cataracts, and cardiac conduction defects can also occur. This is why recognizing these diverse symptoms and classic physical signs is absolutely critical for rapid diagnosis and intervention in hypocalcemia, which can be a life-threatening emergency.
Absolutely critical. Okay, let's pivot now to the endocrine pancreas, specifically focusing on the islets of Langerhans. These are about 1 million tiny clusters of cells scattered within your pancreas, diligently orchestrating a complex hormonal ballet to manage your energy. Within these islets, we find several cell types, each with its own crucial role. The hayparts produce insulin, which regulates glucose utilization and lowers blood sugar. The A cells secrete glucagon, which stimulates the liver to release glucose, raising blood sugar. The A cells secrete somatostatin, which acts as a local regulator, suppressing both insulin and glucagon release. And the PP cells produce pancreatic polypeptide, which has various gastrointestinal effects. The pancreas isn't just about digestion. Its tiny islets are orchestrating a complex and critical hormonal ballet to keep our energy levels in perfect check.
Indeed, the precision required for glucose homeostasis is astounding, and when it goes awry, the consequences are significant. Our discussion will primarily focus on the two main disorders involving these islet cells: diabetes mellitus, a global health challenge, and pancreatic neuroendocrine tumors.
Diabetes mellitus is, as you said, a global health challenge. It's a group of metabolic disorders all characterized by hyperglycemia, high blood sugar, but caused by defects in insulin secretion, insulin action, or most commonly both. The chronic high blood sugar and metabolic dysregulation lead to devastating secondary damage in multiple organ systems over time, notably the kidneys, eyes, nerves, and blood vessels. In the United States, it's the leading cause of end-stage renal disease, adult-onset blindness, and non-traumatic lower extremity amputations. The prevalence is staggering. Over 30 million children and adults in the U.S. are affected, more than 9% of the population, with the vast majority having type 2. Millions more have prediabetes, where blood sugar is elevated but not yet diagnostic for type 2 diabetes, placing them at significant risk. This is more than just a personal health struggle. It's a global public health crisis of staggering proportions, touching nearly every family and placing an immense burden on healthcare systems and economies worldwide.
An accurate diagnosis of diabetes relies on clear criteria. Normal blood glucose is tightly maintained between 70 and 120 milligdl. Diabetes is diagnosed if you have a fasting plasma glucose of 126 milligdl or higher, a random plasma glucose of 200 milligdl or higher with classic symptoms, a 2-hour plasma glucose of 200 milligdl or higher after an oral glucose tolerance test, or a glycated hemoglobin HbA1c level of 6.5% or higher. These tests usually need to be confirmed on a separate day. Prediabetes is defined by slightly lower but still elevated glucose or HbA1c levels, indicating an increased risk for developing full-blown type 2 diabetes and cardiovascular complications.
While high blood sugar is the common thread, the underlying problems in diabetes vary widely. The current classification helps us understand the fundamental differences. Type 1 diabetes, T1D, is an autoimmune disease where the body's immune system mistakenly attacks and destroys the insulin-producing beta cells, leading to an absolute deficiency of insulin. It accounts for about 5–10% of diabetes and is most commonly diagnosed in younger individuals. Type 2 diabetes, T2D, accounting for 90–95% of cases, is a more complex story involving both peripheral resistance to insulin's action and an inadequate insulin secretory response from the beta cells. Most patients with T2D are overweight, and while traditionally adult onset, its prevalence is alarmingly increasing in children and adolescents. The old labels don't fully capture the nuances. It's about understanding the why behind the hyperglycemia, because the underlying mechanisms for type 1 and type 2 are fundamentally different.
Exactly. To truly understand diabetes, we first need to appreciate normal glucose homeostasis. This is tightly regulated by three main processes: glucose production in the liver, glucose uptake and utilization by peripheral tissues, especially muscle, and the finely tuned actions of insulin and glucagon. Insulin and glucagon have opposing yet complementary effects. In a fasting state, low insulin and high glucagon ensure the liver releases glucose to prevent low blood sugar. After a meal, insulin levels rise and glucagon falls, promoting glucose uptake and utilization, particularly by skeletal muscle, which is crucial for preventing high blood sugar.
And the regulation of insulin release itself is incredibly intricate, isn't it? Insulin is produced in the Bose cells as a precursor, then cleaved into the mature hormone in C-peptide. Both are secreted in equal amounts, making C-peptide a useful marker of most cell function. Glucose is the primary stimulus for insulin release. When blood glucose rises, it enters Bose cells, triggering a two-phase release of insulin. The first is an immediate release of stored insulin, followed by a more sustained release involving new insulin synthesis. Incretins are also crucial here, highlighting the gut-brain connection. When you eat, your gut releases hormones called incretins, primarily GIP and GLP-1, which amplify insulin secretion from Bose cells. This incretin effect also helps reduce glucagon secretion and slows gastric emptying, promoting satiety. In T2D, this incretin effect is significantly blunted, and restoring its function with drugs like GLP-1 receptor agonists or DPP-4 inhibitors has become a key therapeutic strategy, not only improving blood sugar control, but also often leading to weight loss. The sophisticated interplay between your gut hormones and your pancreatic islets reveals a beautifully complex feedback system. And understanding this allows us to design incredibly targeted therapies.
Absolutely. And insulin's actions and signaling pathways are equally profound. Insulin is the most potent anabolic hormone, promoting growth and synthesis throughout the body. Its main job is to increase glucose transport into muscle and fat cells, providing them with energy. In muscle, glucose is stored as glycogen or burned for energy. In fat tissue, it's used to synthesize and store lipids. Insulin also promotes protein synthesis and inhibits its breakdown. On a molecular level, insulin binds to its receptor, triggering a cascade of internal signals that ultimately lead to increased glucose uptake, reduced glucose synthesis, and enhanced glycogen and protein synthesis. For instance, insulin causes glucose transporters, GLUT4, to move to the cell surface, allowing more glucose to enter. Insulin isn't just a sugar regulator, it's a master architect of anabolism, meticulously building and maintaining the body's cells and energy stores through a cascade of precise molecular signals.
Now that we've grasped the fundamental differences, let's dive into the fascinating, albeit complex, origins of each type of diabetes. But first, here's a quick rundown on the key distinctions between type 1 and type 2 diabetes. T1D usually has an early onset, often with weight loss, and involves a progressive decrease in insulin due to autoimmune destruction of van cells. T2D, on the other hand, typically has an adult onset, often in obese individuals, and involves insulin resistance coupled with an inadequate van cell response. These fundamental differences in mechanism dictate vastly different approaches to treatment.
Right. Let's explore the pathogenesis of type 1 diabetes, the autoimmune attack. T1D is an autoimmune disease where the body's own immune cells, specifically T cells, mistakenly attack and destroy the insulin-producing bow cells in the pancreatic islets. While often developing in childhood, it can occur at any age. Most T1D patients ultimately require insulin for survival to prevent severe complications like ketoacidosis. The development of T1D is a complex interplay of genetic and environmental factors. Genetic susceptibility is strong, with significant links to specific HLA genes and other immune-related genes. However, environmental factors remain somewhat enigmatic, though viral infections have been suggested as potential triggers through molecular mimicry. The destruction of bow cells is a gradual process, often taking years before symptoms appear. It involves a fundamental failure of self-tolerance in T cells specific for islet antigens. These autoreactive T cells infiltrate the pancreas, causing injury and ultimately leading to the destruction of Go cells. While autoantibodies against islet antigens are present in most T1D patients, it's the T cell-mediated attack that's considered the primary mechanism of destruction. T1D is a slow-motion autoimmune war, silently eroding the body's insulin-producing capacity for years before symptoms finally erupt, demanding intervention.
That's a powerful description of T1D. Now let's turn to the pathogenesis of type 2 diabetes, the story of resistance and exhaustion, which is fundamentally different and has no autoimmune basis. T2D is a complex interplay of genetic predisposition and powerful environmental factors. Genetically, there's a strong heritable risk, with numerous genes linked to cell function, fat distribution, and obesity. However, environmental factors are the major drivers, with obesity, particularly visceral obesity, around the organs being the most important risk factor. A sedentary lifestyle is also an independent risk factor, and the combination of obesity, high blood sugar, elevated cholesterol, and hypertension is known as metabolic syndrome. Factors like sleep disorders and circadian rhythm disruption are also increasingly recognized as contributors to insulin dysregulation. The core metabolic defects in T2D are twofold: insulin resistance and bow cell dysfunction. Insulin resistance means your peripheral tissues, muscle, fat, and liver don't respond normally to insulin. This leads to the liver overproducing glucose, muscles failing to take up glucose after meals, and fat cells releasing too many free fatty acids. This resistance often predates high blood sugar and is initially compensated by the big cells working overtime and producing more insulin. But over time, the big cells can't keep up, leading to chronic high blood sugar. Obesity significantly contributes to insulin resistance through several mechanisms. Excess free fatty acids, particularly from central adipose tissue, can overwhelm metabolic pathways, leading to the accumulation of toxic lipid metabolites that attenuate insulin signaling. Adipose tissue also acts as an endocrine organ, releasing adipokines. Some promote high blood sugar, while others, like adiponectin, which is reduced in obesity, increase insulin sensitivity. Furthermore, T2D involves a chronic low-grade inflammatory state. This isn't autoimmune, but rather driven by pro-inflammatory cytokines released in response to excess nutrients, further promoting insulin resistance. The stress of managing these imbalances can also lead to big cell dysfunction and eventual exhaustion, where they simply can't produce enough insulin. Type 2 diabetes is a perfect storm of genetic predispositions meeting environmental pressures, all conspiring to overwhelm the body's finely tuned metabolic controls, leading to both resistance and eventual cell exhaustion.
We also have rarer monogenic forms of diabetes, which result from specific genetic defects in either both cell function or insulin receptor signaling. These are distinct from T1D and T2D. An example is maturity onset diabetes of the young, MODY, which resembles type 2 diabetes but typically occurs in younger individuals and is caused by germline mutations in specific genes that affect both cell function. Additionally, certain rare genetic defects can impair how tissues respond to insulin, leading to severe insulin resistance.
And pregnancy can also complicate diabetes, right? This occurs either in women with pre-existing diabetes or those who develop gestational diabetes for the first time during pregnancy. Pregnancy itself creates a diabetogenic state, a hormonal environment that favors insulin resistance. While gestational diabetes usually resolves after delivery, most affected women will develop overt type 2 diabetes within 10-20 years. Poorly controlled diabetes during pregnancy carries significant risks for the fetus, including increased risk of stillbirth, congenital malformations, and excessive birth weight, leading to long-term health issues for the child. Pregnancy acts as a metabolic stress test, unmasking underlying predispositions to diabetes with significant lifelong consequences for both mother and child.
Absolutely. The diverse clinical features of diabetes make it a complex disease to diagnose and manage. In type 1 diabetes, the progression from presymptomatic to overt disease can be abrupt, often triggered by stress. The classic triad of diabetes polyuria, frequent urination, polydipsia, excessive thirst, and polyphagia, increased hunger, often marks the onset of T1D, along with ketoacidosis. Insulin deficiency leads to a catabolic state, high blood sugar from diminished glucose assimilation, and profound water and electrolyte loss from osmotic diuresis. The breakdown of fats and proteins fuels hunger, but despite increased eating, catabolic effects prevail, resulting in weight loss. The classic triad of diabetes isn't just a list of symptoms, it's a dramatic chain reaction, each problem fueling the next, all stemming from that initial profound insulin imbalance.
That chain reaction vividly illustrates the body's struggle. Now let's talk about the acute metabolic complications, which can be life-threatening. Diabetic ketoacidosis, DKA, is a severe acute complication, primarily of T1D, often triggered by missed insulin doses or severe stress. Without insulin, glucose cannot enter cells, and the body breaks down fat for energy, producing ketone bodies, which are acidic. This leads to severe hyperglycemia, dehydration, and a dangerous drop in blood pH. Clinically, DKA presents with fatigue, nausea, abdominal pain, a distinctive fruity breath odor, and deep labored breathing. If untreated, it can lead to coma and death. For type 2 diabetes, particularly in older patients, another acute emergency is hyperosmolar, hyperglycemic state, HHS. This is caused by extreme dehydration due to sustained high blood sugar, typically without significant ketoacidosis. Symptoms like nausea are absent, often delaying medical attention until severe dehydration and altered mental status occur, with blood sugar levels often much higher than in DKA. And then there's hypoglycemia, or low blood sugar, the most common acute complication once treatment for diabetes begins. This could be caused by missed meals, excessive exercise, or too much insulin. Symptoms include dizziness, confusion, and sweating. And if left untreated, it can lead to loss of consciousness and permanent neurological damage. Rapid reversal with oral or IV glucose is critical. This is the delicate balance. The very treatments designed to control high blood sugar can, paradoxically, push the body into another life-threatening extreme if not managed precisely, highlighting the constant vigilance required.
Exactly. While the acute complications are dramatic, it's the chronic complications of diabetes that lead to much of the long-term morbidity and mortality. These insidious effects, seen in both T1D and T2D, are primarily due to damage in both large and medium-sized blood vessels, diabetic macrovascular disease, and small vessels, diabetic microvascular disease, all driven by chronic hyperglycemia. Macrovascular disease accelerates atherosclerosis, significantly increasing the risk of heart attacks, strokes, and lower extremity ischemia. Microvascular disease profoundly affects the retina, kidneys, and peripheral nerves, leading to diabetic retinopathy, nephropathy, and neuropathy. While the acute complications are dramatic emergencies, it's these slow, insidious, chronic damages that lead to the devastating long-term impact of diabetes, profoundly affecting quality of life and lifespan.
So how does high blood sugar cause all this long-term damage? What are the mechanisms?
Well, the pathogenesis of these chronic complications points directly to persistent hyperglycemia or glucotoxicity as the primary driver. Maintaining tight glycemic control is shown to ameliorate complications. At least 4 distinct molecular mechanisms link hyperglycemia to peripheral tissue damage. First, the formation of advanced glycation end products, AGEs. These are created when excess glucose-derived metabolites react with proteins, forming harmful crosslinks. AGEs bind to specific receptors, warn age, triggering inflammation and further damage in blood vessels, contributing to accelerated atherosclerosis and microvascular disease. They also stiffen collagen and make capillaries leakier. Second, excessive activation of protein kinase C, PKC, by high glucose levels leads to further vascular damage, promoting the production of growth factors and procoagulant proteins. Third, disturbances in polyol pathways mean excess glucose is shunted into a metabolic pathway that depletes a vital antioxidant, leading to oxidative stress. This pathway contributes to complications like cataracts. Fourth, hexosimine pathways are hypothesized to contribute to cell damage and oxidative stress under hyperglycemia. The chronic complications of diabetes aren't just from high sugar, they're a complex molecular assault. A cascade of damage orchestrated by multiple biochemical pathways, each contributing to long-term organ damage.
And the morphology of these chronic complications paints a vivid picture of that damage, right? Visible changes in organs. In the pancreas itself, in T1D, you'd see a dramatic reduction in the number and size of islets, along with insulitis and infiltration of immune cells. In T2D, there's a more subtle loss of muscle mass and characteristic amyloid deposition within the islets. Diabetic macrovascular disease manifests as accelerated atherosclerosis in large arteries, leading to heart attacks and strokes, and can cause gangrene of the lower extremities. Diabetic microangiopathy, a consistent feature, involves diffuse thickening of basement membranes, particularly in the capillaries of the retina, kidneys, and nerves. Despite the thickening, these capillaries become leakier.
Absolutely. And diabetic nephropathy highlights the kidney's profound vulnerability. Renal failure is second only to heart attack as a cause of death in diabetics. It involves 3 main lesions: glomerular lesions, like widespread capillary basement membrane thickening, diffuse mesangial sclerosis, and nodular glomerulosclerosis, or Kimmel-Steele-Wilson disease; renal vascular lesions, accelerated atherosclerosis and arteriolosclerosis, and increased susceptibility to pyelonephritis. These progressive changes often lead to kidney ischemia, fibrosis, and eventual kidney failure.
Which raises the question, why are the kidneys so profoundly vulnerable in diabetes? And how do these intricate structural changes explain that devastating progression to renal failure?
It's a combination of factors: the high glucose load, the altered blood flow dynamics due to vessel damage, the AGEs, the PKC activation. They all converge on the delicate filtering structures of the kidney, the glomeruli. Over time, this leads to scarring, loss of function, and ultimately, failure.
And the eye is also profoundly affected, leading to significant ocular complications. Diabetes-induced hyperglycemia causes acquired opacification of the lens, known as cataracts, and can contribute to glaucoma. However, the most profound changes occur in the retina, manifesting as diabetic retinopathy. The fundamental lesion here is neovascularization, the growth of new, fragile blood vessels, directly attributable to hypoxia-induced expression of a growth factor called VEGF in the retina. Modern treatments often involve anti-angiogenic agents that block VEGF. Diabetic neuropathy is another significant complication, affecting up to 50% of patients with long-standing disease. It can damage the central, peripheral, and autonomic nervous systems. Most commonly, it presents as a distal symmetric polyneuropathy of the lower extremities, affecting both motor and sensory function, eventually progressing to a glove and stocking pattern. Autonomic neuropathy can cause problems with bowel and bladder function and erectile dysfunction. Patients with diabetes also suffer from enhanced susceptibility to infections of the skin, lungs, and urinary tract. A seemingly minor toe infection, especially in someone with neuropathy, can quickly escalate to gangrene, bacteremia, and pneumonia, potentially leading to death. This enhanced susceptibility is multifactorial, involving decreased immune cell function and impaired delivery of immune components to infection sites due to vascular compromise. While diabetes remains largely a lifelong disease, pancreatic islet cell transplantation offers hope for some with type 1. And for milder type 2, lifestyle changes can significantly improve control. However, most patients will eventually require some form of therapeutic intervention to maintain glycemic control. This profound impact on every system underscores why understanding diabetes is so critical.
Indeed. Now, moving beyond diabetes, let's briefly turn to pancreatic neuroendocrine tumors, or PANETs, a more precise term for what were once called islet cell tumors. These are rare, accounting for only 2% of all pancreatic neoplasms. They can occur anywhere in the pancreas and often secrete pancreatic hormones, though some are non-functional. It's often challenging to predict their behavior from their microscopic appearance alone, though a higher proliferation index can indicate more aggressive potential. Unequivocal malignancy is defined by metastases, vascular invasion, or local infiltration. While insulin-producing tumors, insulinomas, are benign in about 90% of cases, other functioning and non-functioning PANETs are malignant in a much higher percentage. The pathogenesis of sporadic PANETs has been illuminated by genome sequencing, revealing recurrent mutations in key genes like MEN1, PTNN, TSC2, affecting the mTOR signaling pathway, and ATRX-DAXX, which are involved in telomere maintenance. The three most common and distinctive clinical syndromes linked to functional pancreatic endocrine neoplasms are hyperinsulinism, hypergastrinemia leading to Zollinger-Ellison syndrome, and those associated with familial MEN syndromes.
Okay, let's start with hyperinsulinism, typically caused by insulinomas, which are micelle tumors. These are the most common pancreatic endocrine neoplasms and often produce enough insulin to cause clinically significant hypoglycemia, low blood sugar. The classic symptoms are hypoglycemic episodes, blood glucose below 50 mg/dL, leading to confusion, stupor, and even loss of consciousness. These episodes are often triggered by fasting or exercise and are promptly relieved by food or intravenous glucose. Insulinomas are usually benign, small, encapsulated nodules within the pancreas. Diagnosis involves high circulating insulin levels and a high insulin-to-glucose ratio. Surgical removal usually resolves the hypoglycemia. It's crucial to remember that many other conditions can cause hypoglycemia, so a thorough differential diagnosis is vital.
Next up is Zollinger-Ellison syndrome, caused by gastrinomas, which are tumors that hypersecrete gastrin. These tumors can arise not only in the pancreas, but also frequently in the duodenum or peripancreatic soft tissues. The high gastrin levels lead to excessive gastric acid secretion, causing severe, often multiple, and therapy-resistant peptic ulcers in the stomach and duodenum, and sometimes in unusual locations like the jejunum. Over half of these tumors are already locally invasive or have metastasized at diagnosis, and about 25% occur with MEN1 syndrome. Treatment focuses on controlling gastric acid secretion and surgically excising the tumor. Other rare pancreatic endocrine neoplasms exist. Glucagenomas, for instance, produce glucagon and are associated with the syndrome of mild diabetes, a characteristic skin rash, and anemia. Somatosatenomas secreting somatostatin can cause diabetes, gallstones, and steatorrhea. Vipomas, which release vasoactive intestinal peptide, VIP, induce a syndrome of watery diarrhea, low potassium, and low stomach acid. And while extremely rare, some pancreatic tumors can also produce serotonin, leading to carcinoid syndrome, or secrete multiple hormones simultaneously. To consolidate these key concepts for pancreatic neuroendocrine tumors, PANETs are rare, diverse, and can be functional or non-functional. Their genetic pathogenesis often involves mutations in genes like MN1, PTHG2, and ATRX-DAXX. Insulinomas are the most common, causing hypoglycemia. Gastrinomas lead to Zollinger-Ellison syndrome with severe peptic ulceration. Other rare types cause distinct syndromes based on their secreted hormones. As our understanding of these rare but often aggressive tumors grows, can we leverage novel genetic insights to develop even more effective targeted therapies and improve the grim prognosis for the most malignant forms?
That's an incredibly important question to ponder as we conclude this deep dive into the endocrine system. From the master control of the pituitary to the metabolic maestro of the thyroid, the calcium guardians of the parathyroids, and the glucose gatekeepers of the pancreas. We've navigated a complex landscape of hormonal balance and profound disruptions. Understanding these intricate systems, their genetic underpinnings, and their far-reaching effects truly gives us a shortcut to being well-informed, pushing us beyond the surface. Thank you for joining us on this enlightening journey through the deep dive. We hope you feel not just informed, but truly a master of this intricate information, ready to connect the dots in new and insightful ways. Until next time, keep exploring, keep questioning, and keep diving deep.